Today, I want to talk with you about rotator cuff injuries. Hey everybody, I'm Rafael Salazar, occupational therapist and owner of ProActive Rehabilitation Wellness, and today I want to talk with you about rotator cuff injuries. So, when I was at the Department of Veterans Affairs, I was lead clinician in the outpatient specialty clinic, which is fancy talk for anybody who had any issue with the shoulder, neck to fingertips, that was not solved with one of the specialty clinics, so orthopedic surgery, or if they did have surgery, emergency department. If you weren't able to get it taken care of, whatever pain or dysfunction, taken care of through primary care, or you came through a specialty clinic, you came through our clinic, right? So I saw a bunch of folks with rotator cuff injuries, and there was a wide variety of outcomes, right? Some people got better without any kind of surgery. Some people went and got surgery. Some people went and got injections and felt better after the injections. Maybe they had some OT or PT, had an injection, felt great, never had to come back. I'm going to talk really high level kind of rotator cuff injuries. What's the prevalence? What does the research say about the treatments, the treatment options that are out there? And then comparing specifically conservative management, so physical therapy, occupational therapy, exercise, versus sticking and cutting, right? so let's dive in. If you have shoulder pain, you're not alone, right? So right behind low back pain is shoulder pain. So it's something that most everybody in the world will experience some kind of shoulder dysfunction at some point in our life, right? It's a very common reason that patients may schedule an appointment with a doctor, specialist, orthopedic surgeon, right? While there are many causes of rotator cuff injury or dysfunction, I can't sit here and tell you that, oh, you probably have this muscle going on. I can tell you that, it's oftentimes when we tear the rotator cuff, the supraspinatus is one of the most commonly torn muscles, but there's so many things going on. There's 17 muscles that attach to your shoulder blade, and the shoulder blade is very much involved with the functioning of the glenohumeral joint and can cause impingement if it's out of whack. So you can't just look at one video and say, okay, ProActive or Rafi says that it's probably this muscle. There are tons of causes out there, tons of variability. I'm just going to give you kind of a big 30,000 foot overview of rotator cuff dysfunctions, the prevalence of them, and then kind of what the research shows about treating it. So don't take this as like straight medical advice. If you're having shoulder pain, a shoulder issue or dysfunction, sure, you can search some exercises. I always advocate some kind of exercise regimen, even as you're going to see an orthopedic surgeon, because the research kind of shows that strength is always important, right? Strengthening and mobility and all that kind of stuff. So moving on, 7 out of 10 patients with shoulder pain have some kind of rotator cuff injury. So what that means is nearly 70% of the people that go to an orthopedic clinic for a shoulder pain or some kind of shoulder dysfunction have a problem with their rotator cuff. That's what's causing their pain or their dysfunction. That's ultimately why they're there in the clinic, right? So even though 7 out of 10 patients with shoulder pain have some kind of rotator cuff injury or disease, there's still a lot of confusion about which treatment option is best. Pitting conservative treatment versus invasive treatment. What are the outcomes long term? So let's dive a little bit into that. I'm going to link to all of the articles in the show notes if you want to go and read the source articles. We've also done an article about this on the website that you can read it kind of in context, because I know sometimes in video somebody might quote an article here or there, but it's hard to see it outside of context. So we do have an article. I'll link to that down there as well. For the rotator cuff dysfunction, treatment ranges from injections, surgery, or physical and occupational therapy, or sometimes just home exercise program. Do these stretches, do these exercises at home, right? The result of each treatment option in the literature tends to be mixed and unclear. So one of the big studies out there shows that operative intervention, so surgery, you're going to have the same outcomes as if you had not had rotator cuff surgery. Whenever you look at these kind of studies, you always have to look at the outcomes that they're following. Some of these studies will look at pain as their primary outcome. Some will look at strength as their primary outcome. Some will look at function, so their ability to reach up overhead. So you really need to look at what are these studies measuring as their outcome when they say there's no difference between physical therapy or occupational therapy and surgery. So for example, one study shows that the visual analog scale, so the pain scale that we use, they follow these patients for 12 months. There were two groups. One group had surgery, one group did not have surgery. And there was a statistically significant difference between the outcomes of the surgery group when compared to the non-surgical group. So what that means is basically the people that had rotator cuff surgery after 1 year had a statistically significant, means that it was a valid measurement or a valid change that we can attribute to the treatment itself from surgery. They had less pain than the non-operative group. However, there's a difference between what we call quote unquote statistically significant, which means that yes, it's a real change that we can attribute to the surgery or to the treatment, and what is called clinically significant. So something that is clinically significant is something that actually makes a difference in the quality of life. While there was a quote, maybe a change on a scale of 1 to 10, it was not so much of a change or so much of an improvement over the non-surgical group that we would consider it impacting their quality of life of the participants. There's a big difference, and it gets very confusing. I used to teach this at the university, and wrapping your head around this idea of, okay, just because something changes, just because it's something that's statistically significant, doesn't necessarily mean it's clinically appropriate or clinically significant. So there is a difference between, okay, we made a change, that's great, but does this change actually lead to quality of life improvement? And in these studies, the ones that we've found and we've cited here, we'll link to them again in the show notes, while there are statistically significant changes, they're not clinically significant. Think of it this way. A statistically significant change for the numerical rating scale of pain would be about 1.39. So on a scale of 1 to 10, if you go from being at a 9 out of 10 to being at a 7 out of 10, that's statistically significant. However, if you're at a 9 out of 10 and you can only back it down to a 7 out of 10, would you consider that a clinically significant? Has that really improved your life? No, you're still in a whole lot of pain, right? So if you started, for example, as a 10 out of 10, you were only able to lower it to an 8 out of 10 through surgery, would that be worth it to you? Sometimes the answer is yes. Sometimes the answer is no. Sometimes the answer is maybe. In the end, when it comes to pain as a primary outcome measure, all the studies say this, but what we need is more studies with longer follow-ups, because it's one thing to say, okay, 6 months after surgery, the pain is actually higher in a post-operative group, or 12 months after surgery, it's actually lower in a post-operative group, but we don't have a whole lot of studies that follow farther beyond that. What a lot of the research does show and does say, passive treatments alone are not going to get you long-term outcomes. So passive treatments is anything where you're sitting down and the clinician, the doctor, the physical therapist, whatever, is doing something to you rather than doing something with you. In the case of shoulders, for example, a shoulder pain or rotator cuff issue, you might need a passive modality or passive treatment right off the bat. You might need an injection. You might need a surgery to get over the hump or to repair whatever's going on physically. However, for long-term outcomes, even after that surgery, you're going to need to do some sort of activity, usually in the form of movement, of exercise, in order to have long-term positive outcomes. One meta-analysis that we'll link to again down below, comparing surgery versus therapy for rotator cuff, found that, and I'm going to quote here, there is limited evidence that surgery is not more effective in treating rotator cuff tears and injuries than conservative treatment alone. There was no clinically significant difference between surgery and active physiotherapy, which would be physical or occupational therapy for those of us in the United States. In 1 year post-op, following the improving the constant score, a pain outcome, or reducing pain caused by rotator cuff tear. As physiotherapy is less prone to complications and is less expensive than surgery, a conservative approach is advocated as the initial treatment modality for rotator cuff tear. So even if you do have a rotator cuff tear, the research suggests that long-term, having surgery versus not having surgery, you might end up in the same place in 24 months, in 2 years, as if you had surgery, except you would not have taken the risk of anesthesia, of post-operative infections, of a wound dressing issue or something like that. The research does kind of suggest that what we want to do is consider conservative treatment, physical therapy, occupational therapy, some kind of stretching or exercise or movement-based therapy, because you're going to get the similar outcomes, comparable outcomes as you would have had during surgery, except you're negating all of the risks of surgery. And really, orthopedic surgeons, the ones that are really worth their weight, will tell you that. They'll say, listen, we can do XYZ, but it's a lot of risk. Why don't we try physical therapy first? And if you're not better, if it does not lead to improvement in quality of life or decreased pain or whatever the metric that you want to focus on is, then we'll come back and we'll talk about injections and surgery. But conservative treatment should always be the first line of treatment, even if you have something like a documented rotator cuff tear. If you have a minor rotator cuff tear, even on an MRI, the research still shows that you should try conservative treatment before you get surgery, just because the outcomes are similar or comparable, and you're not taking the risk, potential complications of surgery, namely when it comes to anesthesia and infections. These studies conclude that because surgery and therapy both yield similar results and outcomes when it comes to pain and function, specifically pain and function, then it doesn't make sense to jump straight to surgery. The authors of the study suggest that starting with conservative treatment options like physical and occupational therapy, maybe even aquatic therapy or something like that, and the like, should be done before you move to more invasive treatments or more expensive treatments or more risky treatment. There's never a one-size-fits-all. Just because you have pain doesn't mean that there's a silver bullet for you. Treatment options and approaches should be based on the goals that you have for yourself. Is it just decreased pain, or is there some kind of activity that you want to get back to? I've treated folks that all they wanted was the pain in their shoulder to be done. And then I've had folks that say, you know what, I'm willing to deal with a little bit of pain, but what I really want to do, no joke, I had a guy who was a rock climber, and he wanted to get back to rock climbing. He's like, listen, I know I'm going to have a little bit of shoulder pain, a little bit of soreness after rock climbing, but that's something that I really want to get back to. So that was his main goal. And his treatment outcomes or his treatment plan is going to look a lot different than somebody who just wants pain gone. So you should take all of this into consideration. You should talk about it with your physical therapist, with your doctor, with your occupational therapist. Discuss your unique situation, your unique context, what we call it here at the clinic, and any other, environmental, work-related factors that may affect your specific situation, your specific participation in treatment, and what might affect your outcomes. The research suggests that starting with less invasive treatments and less expensive treatments, and reserving surgery for more and more invasive treatments for later down in the treatment plan is ideal. You should speak obviously to a physician, to maybe an orthopedic surgeon if you've already discovered that you've got some kind of rotator cuff dysfunction and you're wanting to kind of take the next step. Talk to a doctor about your specific situation and whether it makes sense to start with something like a conservative treatment approach. The research would indicate yes, but whether it makes sense given your specific situation, whether to start with something like that or go right into surgery. Again, depending on what you've got going on, most of the research does show that we want to start with conservative treatment and move more towards invasive treatment in later stages of the treatment plan. However, your own situation might be different. You might have something going on that I can't see on your MRI or your x-ray. So obviously talk to your doctor about it. I think one of the main takeaways is that quote from the big meta-analysis about surgery versus non-surgical. And I'm just going to read it again because I think it's powerful enough to read it again. So quote, there's limited evidence to suggest that surgery is not more effective in treating rotator cuff tear than conservative treatment alone. There's no clinically significant difference between surgery and active therapy and 1-year follow-ups improving the constant score for pain or reducing pain caused by rotator cuff tear. As physiotherapy, so physical and occupational therapy, is less prone to complications and less expensive than surgery, a conservative approach is advocated as the initial modality of rotator cuff tears. Again, I will link to all of the studies below. I'll link to the article that we did about rotator cuff repair versus physical therapy, and you can read about it there for yourself, and we have links to all of the studies from there as well. Healthcare is one of those few areas where you're in a position where you're forced to, or you're required to, or expected to make decisions, and you really have very little information about it. Unless you're reading a lot of literature about rotator cuff tears, about outcomes, reading the clinical journals, it can be very difficult when a doctor says, or a clinician says, okay, your options are surgery, injections, or physiotherapy. What do you want to do? So our goal here at ProActive is to give you the information you need to make informed decisions about your own health, your own well-being, and charting your own path to recovery. So until the next time, be safe, be healthy. I will talk to you then.